numbers and makes our life a little bit easier during on-calls and also making decisions without have to touch the patients. So I was tasked to give some case sharings on Swan-Ganz, in particular heart failure. I will share 3 cases that I often encounter when I'm having attachment back in Singapore. But because this is something that is rather new to our own community here in PJS, so probably I'll just start off with a little bit of introductions of the PA cath or the right heart cath Swan-Ganz. Generally, the catheter is there to measure pressures. So that's the baseline. So what pressures are we measuring? It depends on where is the catheter put into. So if let's say you have a catheter put into the artery, you are measuring artery pressure. But if you are putting it in the PA cath, means it's pulmonary artery cath, you are measuring the pulmonary artery catheter. To reach the pulmonary arteries, we need to go through right atrium, right ventricle, to pulmonary artery, and then into the lung. So on the way, you will measure all these RA pressure, RV pressure, everything. So making sense of the pressure is to help us to measure what? Number 1 is cardiac output. Number 2, the chamber pressures, and we try to know what it means. And also in the end, we also can assess intracardiac shunts by assessing the saturations of each of the chambers over the right side and tell us whether there's any shunts going on. Nothing comes with free lunch, although we have free lunch today. So our complications of insertions is as if what we are doing every day, insertions of our dialysis catheter. Just that it depends on where you poke the patients. Generally, bleeding, hematoma, puncture through and through, and leave the catheter there for a few days. And when you take out, patient is spurting away, developing AV fistula. These are actually quite common. And because the catheter goes into the RVs, so sometimes it can cause RV perforations, which is not so common, but can happen, like what we did to our own TPM patients sometimes. And then, of course, the catheter was left there very long time. It may develop clots, and eventually we move around every day, want to wedge, push in, unwedge, take out, then dislodge a clot and cause pulmonary embolism. So this is the pictures. Then later on, I think we have some samples that are for O to just have a look. But generally, there are few ports in this pulmonary catheter, the Swan-Ganz. A little A there, which is in blue color. It is the proximal lumen. If placed properly in our heart, it will be measuring the RA pressures. The hole will be at the RA place level. B, it will be distal lumen, which is the tip of the very tip of the catheter. Okay, we are measuring pressures. If this tip is at the pulmonary artery, then you'll be measuring pulmonary artery pressure. And letter C, which is connected to a syringe there. Okay, letter C in red color is used as to inflate the balloon, which to cause the wedge. Okay, and letter D is our usual line. We want to infuse anything from there. We can use that port. And letter E, which is with a red cap there, that is our thermistor. Is for thermal dilution. Measuring of cardiac output. So this Swan-Ganz is about 7 French, and then usually we put in an 8 French shift before we can put this catheter in. All right. So where does this thing connect to? Just a picture. It's going to this thing what we call as the transducer. So it is a pressure that is sensed by this line. So and then this line is connected to the transducer. It will be connected to an electrical wire. So the pressure is converted to electrical signals, and later on you will see the waveform. Okay, so that's the idea. And then of course pressure, we are at the earth level right now. Okay, maybe we are at 76, but if you are at high up in the skies, then your pressure will change. If you're deep down in the core of the earth, then the pressure will change. So likewise, we need to make sure that these pressure sensors that we are putting must be at the correct place. Cannot be too high, cannot be too low, or else the hemodynamic would be wrong to be interpreted. So usually it's at the midway of our anterior posterior chest wall, intercostal space. So that is the place. The key point I have highlighted here is that after you flush the catheter, make sure that level of transducer is correct, then we 0 to A. This step cannot skip, and this step need to be done correctly so that there's no rubbish in and then rubbish out the number. Okay. So where do we poke our vascular shift for our patients? Where do we poke? So we can use generally 3 ways. Number 1 is through the internal jugular vein, which I think is the way to go. To make it easier for us to pass the tube in, especially for Swan-Ganz. And number 2, we sometimes can use basilic vein, which is still invasive, but I think the compressions is easier. It's more convenient for the patients to be discharged back home after 4 hours. You don't need to compress here. It's just at the hand. And thirdly, probably we can go through femoral vein, which is a little bit hard actually for talking the Swan-Ganz. So as I said, the Swan-Ganz will pass through the all these chambers, RA, RV, to the main pulmonary, then to right and left pulmonary artery. So that there are markings on the tubing just now. You can see there are black dots. So generally, if we pass into about 20 centimeters, we roughly know from the IJC, we roughly know that we are in the RA already. That time we can start inflate the balloon and let the swan float. Okay, so balloon is inflated when we want to advance. If we want to, let's say you pass through RV, you say, oh, I forget to get RA pressure. So you want to pull back and tap the RA pressure, then please de-balloon it, deflate it, and only pull back, or else you're going to destroy the tricuspid valve also. Okay. So now we say about wedge. So this balloon comes with wedge, means the balloon can inflate, wedge the pressures, and then we measure whatever pressure which is distal to it. So how do we know that we have already successfully wedged? Number 1 is there's a change in the waveform. Okay, just to know that. Number 2, if we take the blood from there, we wedge at the pulmonary artery, the blood saturations that we take will be usually more than 70%. Then we know we are at the right place. Okay, so the good thing about Swan-Ganz in CCU is that we can leave it there like for many days and then we get the numbers. Okay, so you have to park somewhere if you want to leave there. Where do we park the thing? Okay, usually we park at the pulmonary artery, just at the bifurcation part, or just at the tip of the before it enters the right or left. So where is that specific place? The right side of your screen shows, the left side of your screen shows the fluoroscopy view. If we have fluoroscopy in CCU, I think it would be best we can just do in CCU. We don't need to push the patient to our ICL lab. And the one on the right is the X-ray view, how it looks like after that. So where do we park? It's about 2 centimeters away from the hilum. That would be roughly the tip of our entry point of the pulmonary arteries. Okay, so we want to wedge. Can we push the catheter and when you do the fluoroscopy up here, or can we push the catheter at the zone this here, or we can push catheter down here? Which is the best place to say we wedge and then get the correct ones? So the best way is zone 3, because we wedge. We want to measure the pulmonary vein. We're now at the right side of the heart. You want to measure the left side of the heart, which is the pulmonary vein. So how the best place to park the tip when you are wedging is at the zone 3. That is the best place. So this I've sent out to in the group for you all to just remember there's a normal value behind all the measurable pressures and the formulas of the interpreted numbers and what. So this is for you all to keep. Okay. And cardiac output. So now we have all the numbers. Of course, the number 1 thing we want to know is cardiac output. Is it strong? Is the heart weak? Things like that. There are many ways for us to assess the cardiac output. Number 1 is the thermal dilution, which is the red cap you showed just now on the picture. So that is basically you are injecting a saline, and then you let the machine read how fast the cold saline temperature change. That's why it's called thermistor. So how fast it's changed will tell us how strong the heart is pumping, allowing the blood to flow from the proximal port to distal port. Okay, so that's one way. The second way is the FIG. From here, we use the indirect FIG. Indirect FIG, there's a formula for it, but usually we stick to one calculator, key in all these necessary information. The SpO2 we'll get from our mixed blood when we park our catheter at the pulmonary artery level. So you just plug in the the calculators and then calculate it. All right. I shall skip this, all the waveforms. It's just for demonstrations of how it looks like. Generally, ACV wave for our right atrial pressure waveform. This is when you go into the ventricular waveform, okay, right RV waveform. And then when you go up a little bit to pulmonary, you will see the dichrotic notch here. Okay, you know that you are in pulmonary artery waveform. And then when you wedge, it will change from this dichrotic become that, a bit flat with ACV waveform. So you know that you are wedging correctly. Okay. So there are a lot of things to make sense of. What does it mean? I won't go through this, but I will share the 3 cases. So the numbers we get, and then we have a protocol. Just write down all the numbers and sit down and analyze it. That is what we should do now when we try to see what is going to the patients. So that's a little bit of overview of the PA cath. So there are 3 cases that I want to share for usage of pulmonary artery catheters or Swangans in advanced heart failure patients. Number 1 case is we use it on these patients who are coming in of advanced heart failure. How do we use the PA cath to help us? We have a 63-year-old man. He has reduced ejection fraction. He has ischemic cardiomyopathies. Basically, the vessels are non-revascularizable anymore, and many places are non-viable. And he used to be quite fit after he's been diagnosed with ischemic cardiomyopathy. But over the years, we can see that he's sliding downwards in terms of the functionality. So the NY share becomes 1, and then can play badminton, cannot play, can only walk. And this year alone, when he come, he feel very lousy, feel very tired, although it's not very congested, but just feel very tired and become housebound. Walking a little bit will cause him to be very exertional, breathless. Okay, and he has been admitted once this year in January before he come to see us again in the a few months ago. Okay, so this is the creatinine trend over the years. You can see the kidney started to suffer also after the worsening of the heart functions. And the weight is just hovering around that 83. But in fact, he come to see you now. He said, I'm a bit breathless. It's actually dropping weight. So it's also not a good sign when our heart failure patients drops weight. But yes, they are not so congested, but they are breathless. It means that they are developing this cachexia and all the bodies in catabolic state, and slowly patient will just die off. So when we examine the patient blood pressure is only about 80 plus, 90 plus. At best, 1 or 2 numbers would be at 100. Okay, SpO2 is 95%. A little bit of pitting edema, a little bit of ascites, JVP is slightly raised. We can probably classify the patient as very cold and not so wet, but still a bit wet. Okay, NT-proBNP is high, patient is hemodynamically quite congested, and the EF is 25%. So we're dealing with a patient who is chronically having heart failure, slowly sliding down, and being admitted 1 time already, okay, and then the EF is low. Okay, so we can classify these 2 group of patients as patients who are in advanced type heart failure. So when we talk about advanced type of heart failure, it means that many drugs we cannot give. You see, all the drugs that we give can only be a very minimal dose. We don't even know whether it is having effect on the patient or not. 1.25 bisoprolol, 12.5 spironolactone, a bit of bumetanide. Don't dare to give too much because the BP is low. Okay, so this is what happened in the ward when he's admitted. He's feeling very tired and lousy. So on the first days, the urine output is only about 680. We don't dare to give too much. Try to challenge a bit of IV furosemide. Okay, so the blood pressure was only at 90 plus. So step in and we give some dopamine just to improve the renal perfusion a bit. Okay, then the urine comes a little bit better, or 3.5 liters. Then over the days, you can see the urine start to again come down again. All right, and he's not feeling well with the dopamine. He feels very palpitations. Okay, so we have to eventually off it. Okay, it looks like he is drying out a bit, 82 to 79 kilos, quite happy. But then we are stuck. He's still breathless. He's still a little bit edematous, and now the weight is slowly coming up. The urine is like slowly coming down. Okay, so we do not know what to do with the patient at this point of time. I think we have a lot of this kind of patient. We just pray and hope that they don't get lung congestion and discharge them with low dose furosemide and maybe a very low dose of sometimes beta blockers. So that's the usual scenario we face. So how can we help the patient at this point, who is cold, a little bit wet, BP low, okay, in advanced heart failure state? Okay, so we put in a right heart cath just to understand our patients. How is the patient's cardiac output? Okay, is the patient really still congested? Because you look at the legs, you look at the tummy, it's not really that congested. Okay, so when you put it in, we notice that the wedge pressure is very high. So the LF pressure is very high. Patient's volume is a bit overloaded, and you can see the pulmonary pressure is very high. The pulmonary hypertension is very high. Okay, but is this just a left heart disease? Perhaps no, because the PVR, which is our pulmonary vascular resistance, is also high. This shows us that maybe the patient has some form of pre-post pulmonary arterial hypertension. It can be a chronic remodeling of our pulmonary vessels in response to the chronic heart failure. So the left heart is suffering. The cardiac output is very low. Number two, it's very overloaded. The wedge pressure is very high. And number three, the pulmonary pressure also very high because perhaps there's a lot of water inside, okay, and it remodels and patient is in a lousy state. But the lactate is not too bad at that time, it's 1.0. So maybe it's just enough, just compensated enough for the perfusion. The MEP calculated at that time is 82. So having seen this, we know the patient is overloaded. We are very convinced. If you just touch the leg, see the tummy, really very hard for us to make the decision whether patient is dry or not too dry, or a little bit wet or a lot of wet. So this is very wet. Okay, so we decided to change the infusions 5 mg, bring him down to CCU, give some infusions, stop anything that brings down the heart rate, which will reduce the cardiac output. So we hold the evobrading and also stop the spironolactone, let the furosemide play the game first. Okay, so second day we come and see him. Yes, we are happy that the pulmonary wedge pressure start to come down a little bit. Okay, patient's urine output is quite good overnight. Suddenly can 2.7 liter without us having to touch the dopamine also. Okay, so we are quite confident we are heading correct way in terms of diurizing the patients. Okay, but patients still cardiac output is quite low at this point of time. Okay, so and the SVR, which is the systemic vascular resistance, is a bit tight. Maybe the body is trying to compensate by vasoconstricting and increase the blood pressure for us. Okay, so the higher the SVR, the harder the heart had to pump against the afterload. So in the sick heart, you don't want the heart to do like that. You want the heart to pump against a lower pressure, make it easier to work, make it recover. Okay? So at this point of time, we decided to add on a bit of dilator, increase the contractility, but relax the vessel a bit and continue the diuresis. So we hope that we can increase the cardiac index, and we hope that we can reduce SVR a bit. Okay, so I just show the next, just few hours later, 4 to 6 hours later, we think the patients can tolerate the Mirino because it's an inodilator. Sometimes when you give the BP will drop because of inodilatations. So what we do is we increase further, we test a little bit. So that's the rationale behind. Okay, then on the third day, we come back and see him. Patient started to dry out. You can see the RA mean started to jump down from 14 all the way down to the 8. Okay, and then the wedge pressure also quite static already, but it's coming down trend also. But we think that because patient have some form of moderate to severe MR, of course the PCWP will be a bit high at this point of time. Okay, but funnily, we do not know why the SVR is very high at this point of time. Either the patient is compensating or when we are doing the interrogations, patient is in anxious mode. We do not know. But clinically, we know patient is dry. Looking at him, he is also dry, no more edema, urine output is quite good. All right, so we decided, okay, this perhaps is the baseline of the patient. That's the best we can go in terms of drying him up. Okay, so we stop the diuresis. Now we are aiming at how do we help the patient from now on. Does the patient need a long-term inotropy support? Does the patient can tolerate in this kind of situations with some oral forms of GDMTs to help with the heart failure? So from this point onward, we give levosimendan because we know that levosimendan has at least a 2 weeks circulation in the body. It's something that is long enough to stay in the body. Okay, so we want to give this levosimendan so that we can boost the cardiac output a little bit, and then discharge back home patients so that it won't come back so fast. Okay, so that's our thought here. So we started with limosimendin, and Entresto we start because Entresto has the vasodilating effect in the valsartan and some in the sacubitril. So we hope that we can start this test the water whether the patient can tolerate it or not. So what happened next is when we start the levosimendan, not too bad. You can see the SVR start to come down already. Okay, the cardiac index slowly going up trend, but that I think is the best, and patient is still in dry mode now. Okay, so we continue on the Entresto. Okay, but the 4th day, right after we start with the levosimendan, we stop the diuresis and Entresto. Okay, you can see that the cardiac index doesn't really improve much already. It just stay there at 1.7. It's still quite low now. The MAP dropped further a little bit because we start to vasodilate a little bit more. Okay, so we think we are doing too much at the moment. The SVR it dropped further, and then the BP dropped further. Okay, we stop the Entresto, so the vasodilating effect take off. But we just let the levosimendan play the game for the contractility. That's it. Okay. So in the afternoon, we noticed that the numbers doesn't change after we take off the Entresto. Okay, the BP come out already. So we know that at 25 milligram BD, the patient cannot tolerate because the vasodilating effect is a bit strong for him. Okay, so we want to challenge it a little bit next time with Entresto of OD coming morning. Okay, and this point of time, we just want to keep the patient a little bit dry. We know that perhaps a 0.5 14 milligram OM is fine for the patients if he's discharged back home in this condition. Okay, so now we are confident that furosemide we can give a little bit for the patient. Now he probably can tolerate 25 milligram OD, and we start spironolactone back. And we know that the cardiac index will not improve. It's just around there, 1.7, 1.9. This is the best we can do. All right, so that's the last number that we have. So this number is important for us before we discharge the patient. Why? Because if the patient come back in next time, decompensated, things like that, we run another number, it gets more lousy than this number. We know the patient is heading the worst way. So we need to refer them earlier for mechanical circulatory support, things like that. Right? So the patients with has been tested water with Entresto, not too bad of dropping of the blood pressure and also cardiac output. So we keep the patients on Entresto. We keep the patient on a little bit of diuresis, or at this state, we think he can tolerate it, which he can. And we start back all this empagliflozin, spironolactone, guided by the numbers, which give us extra confidence, and looking at the patient, extra confidence that, okay, this is what he can tolerate. Anything he can't tolerate, we know that something is wrong with the hemodynamics. He's going downhill. Okay, so the learning point for this case is that in advanced heart failure, it's very hard for us to titrate medication. It's very hard to know this low BP is okay for this patient or not. All right, so having the hemodynamic numbers for us and titrating when the patient is in the ward with all these numbers, it can help us to decide and at least push up a little bit of the GTMT that can give benefit to the patient's heart failure. So it is good that we practice using PACs on patients who are having advanced heart failure. Okay, it is also quite important for us to monitor the cardiac output, both left and right, from this PACAF, so that we know what mechanical circulatory support to order next time when the patient decompensate. We can confidently tell Dr. Teo maybe, okay, this one got biventricular failure. Can we get biventricular VAD, things like that, or just a single VAD? So those numbers are important. Second one, more straightforward. In cardiogenic shock, a man came in with STEMI, Killit 4 in cardiogenic shock, intubated, pH 6.9. These are the findings of the PCI, the primary PCI coronary findings. Everywhere is obstructed. Mainly, we think the LAD is the worst. So they perform DES, stenting and ballooning of the LAD, thrombectomy, and also the GP2P3A. So IFPP is inserted. Okay, but after 1 hour of all this intervention, patient BP is supported by NOAD of 0.9. A little bit drop of 0.8. The BP will drop already, so they keep at 0.9 and send the patient to CCU. After 1 hour, we can see that the pH is slowly climbing up from 7.0 0.6, 0.14. Lactate is now 4.4. There's no urine output. Okay, definitely this is a cardiogenic shock patients in quite severe metabolic acidosis. Okay, the EF is very down. So is it enough? We only revascularize one vessel. There are 2 more vessels to go, and patient in shock. How do we support the patient so he can survive on to receive probably complete revascularization later on? Okay, does the patient need some LV support at the moment aside from just IABP? Is it enough? Okay, so to know these answers, it's better that we have some invasive numbers to guide us. So at the point we inserted in, somehow the patient's blood pressure is very high. Remember the NOAC is 0.9. Okay, so you can see that the SVR is very high, 2,600. Okay, the vessels are very constricted at the moment, but the heart is very weak to pump. Okay, so we are making the heart working harder, extra harder against a high afterload. Okay, and secondly, patient is also still wet. The wedge is slightly high. The RA mean also very high. So both of the heart is now filled with a lot of water, and the lung is congested. Then the cardiac index is 1.9 despite on no adrenaline. Okay, so what we do is we keep the IPP. We know that IPP can help to reduce afterload and improve the contractility. We reduce the no adrenaline and get the nephro in for the CRT for the acidosis. All right. So when we cut down the no adrenaline, there's no much change in the SVR yet. Okay, because the body's try to compensate by constricting itself against a very low, sudden low cardiac output. Okay, so to help the heart to pump a little bit more and relax the vessel further, we add on inodilator, which is Murinon. Okay, so the Murinon is with hope that we can reduce the SVR afterload, and with hope that we can increase the cardiac index. Right, always start slow to test the water, and 3 or 4 hours later we will increase. Okay, so the next day when we come back, patient is on CRT already. You can see that the cardiac stunning has improved at the moment. The indexes has gone up to 4, is normalizing. The waters after the CRT extractions is also coming down. Okay, so it's not so overloaded at the moment. And the SVR now has dropped all the way down to 900. Perhaps we are giving a bit too much of the Murinon at the moment, plus the IABP, which reduce the afterload very much. So what we do is we plan to off the IABP, reducing the IABP support, and give the titrate off the Murinon. Okay, so we let the CRT continue. When we off the IABP and Murinon, you can see the SVR start to come back to the normal range, and the cardiac index drop down a little bit as we take off the IABP, but it's okay, it's enough at the moment. We just let the CRT do the job. So in cardiogenic shock patient after revascularizations, a lot of times patient is still in shock, and it's because of the metabolic acidosis that prevents the heart from immediate recoveries. So at this point of time, perhaps we need to think of some mechanical support, whether the patient can pull through, whether it's just no ad would be enough or not. We don't know. So we need some numbers to guide us whether the patient is going downhill or up. Okay, of course, clinically we can see that patient is okay, but we cannot act fast by clinically, but number can tell us faster. All right, so it's good that we can practice using some invasive tools to help us to guide the inotropy support and prepare ahead of the mechanical circulatory support in cardiogenic shock. For example, if it's only LV down, the LV output is down, then maybe we can think of escalating impeller or other things. But if the LV and RV both fail, then we probably have to call the surgeon in to help us with ECMO, because just impeller alone or IPP alone cannot support the right side.